Thanks very much, Matt, and it's great to be back again. I did my farewell lecture here in June 2015 when I left as a full-time, and I had so much fun getting that one ready and doing it that when Paul asked me, will you do another one, I thought, well, I'll do the same again. It's not exactly the same, but hopefully this morning I'll be able to showcase the work that we've been doing with the Groin Pain Center team the last 18 months since I left and been coming back on a visiting basis. So show you some of the new data and the studies, but also have a bit of entertainment. And I themed it the same. It's the XMen. It's a showcase. It's a movie. So when we have a movie, we should start. A lot of the series on TV now, they start with like a what happened last time. So since I discovered how to work with that media thing, I made a new trailer. So this is the trailer to get us in the mood for this morning. Here we go. So get your popcorn out. But it's not all going to be me working today. The next bit of the talk this morning is the quiz. So I don't know if you saw in the invitation to download the app of Kahoot. If you didn't download the app, that's okay. We're going to find out who's the Aspetar's own Cerebro, who's got the most groin knowledge. So everybody get your phones out, mobiles at the ready, and you need to go to kahoot.it. So if you downloaded the app, just open the app. If you didn't download the app, just go online now and go to the site kahoot.it and you'll come up on this page. So I'll just give you a minute to do that. There's a chance for a prize, everybody, so it's worth to participate. Is everybody on the site who wants to be on it? Anybody not on the site who's... Okay, so in a minute you'll get the game pin, you type that in, and then you come to the screen, give yourself a nickname, and you'll see your name come up on the screen, so you know you're in the game. Okay, I'll just move to the site. The quiz site. So here's the game pin. Turn down the funky music a little bit. Type in the pin. Who's first? Matt. Rod. There we go. And you should see your name popping up once you're on. Give you a few seconds longer. Come, there's lots of seats at the front, guys. Come down a bit closer. Is anybody still trying to get on who can't get on? Okay, no pressure on the Groin Pain Center employees here. Okay, 40 people ready. Anybody not on who wants to get on? No? Okay, so we can start. Okay, here we go. 7 questions coming up. Each question Here's the first one. Read the question, and then you press the color on your telephone that matches the answer you think it is. It was adductor related. And the quicker you press the correct answer, the more points you score. So, Rod, trigger finger, Mr. Twitter, there we go. Good to see Groin Pain Center scoring highly. Okay, next one coming up, ready? Nearly everybody in. Yep. 85 days. Yeah, if you didn't win that, Andrea. Okay, next one. Palpation. Yeah. Robin is on a streak. There we go. Next one coming up, ready? Can't get enough of that little thing. Kicking, by far. Okay, here we go. Next one, ready? Oh, well done, X-ray woman, keeping up the honor. 44%. And another one, ready? Let's see. Oh, Dave's coming through. Here we go. About half the time. X-ray woman still in the lead. And the last question. All three. There we are. Well done, Andrea. Round of applause. And for you, the XMen keyring. So honored. Okay, so hopefully with the quiz, we should have set the scene a little bit for the rest of the talk. So in today's talk, I want to highlight the work that we've been doing in screening, the work of acute groin injuries, some data from the groin clinic, a study about return to play decision making, and talk about future projects. So if we start with the work in screening, X-ray woman, aka the Australian Andrea Mosler, is coming to the end of her PhD at the moment. She's been working really hard for the past 4 years on this, but we all know that research, you don't do it on your own, it's part of a team, and the data I'll present today is on the epidemiology of injuries in the Qatar Stars League. And Andrea did a fantastic job bringing in, together with rehab, all the clinical data of the players coming through the screening department each year, and is now combining that with the injury epidemiology data. And the injury epidemiology data from the QSL, we have to thank Wolver Karim Shamari and Cristiano Epidirali for their work, but of course not forget the entire of NSMP. I'll show you in a minute the scale of a project like this and what's needed. So a big thanks to all of you who've helped by filling in the injury cards, giving us feedback about what injuries the players are getting, when they're recovered, how much time they've lost, and also bringing the players with injuries to Aspetar for the acute groin study as well. So a massive thanks to all of you. Without your help, we wouldn't be able to present data like this back to everybody. So the QSL groin injuries data study, that's based on 2 seasons. It has 606 football players in it, playing in 17 different teams. And those players over 2 seasons got more than 1,000 time loss injuries. Of those more than 1,000 injuries, 206 are groin injuries, which means 18% of time loss injuries in the QSL are groin injuries. And that gives us an incidence of 1 injury per 1,000 hours of football, which is a pretty abstract figure. So what does that actually mean in terms of at a player or a team level? How can we translate that to a more clinically meaningful data? So what does that mean? It means 21% of players in the QSL gets a time loss groin injury each season. That's 6.6 players on a team getting a time loss groin injury each season. We had it in the quiz already. That's 85 days lost to groin injuries per team per season. And adductor-related groin pain is accounting for about 2/3 of that. So that's a huge injury burden that we face due to groin injuries. The talk today is not specifically about prevention, but I think with such high injury burden, we have to spend a moment to think about prevention. If we want to do something preventive, go where the money is, think mostly about adductor-related groin pain. That's causing by far the most groin injuries. And through the work of Andrea and the team in screening, we've now got the normal data on the hip muscle strength, hip range of motion, which is used already in the screening and used already in the rehabilitation. So that's already become a big part of clinical practice, is using these data to inform us when is a player back up to a reasonable strength. How does their strength compare to the other players in the league? And that's useful data. But the really useful data is just on the way in terms of knowing what are the risk factors for these injuries. Andrea's in the closing stages now of the study on intrinsic risk factors. So does strength, hip range of motion, past history of injury, hip morphology, does that give you a higher risk of sustaining a time loss groin injury? And the final data is due in at the end of January. So hopefully very soon we'll have that answer for you. And following that, the work will start on the extrinsic. So does fluctuations in training load acute on chronic workload ratios. How does that influence the chance of getting a groin injury? So these two studies will be greatly able to inform our preventative practice towards the future. So really looking forward to those coming out. On the topic of acute groin injuries, we have to turn to our Thor, aka Andreas Cerner. Matt already said it, so you stole my thunder a wee bit there, but on the 30th of November he's submitted his PhD, and I planned a round of applause, so we'll give you a second one. A great achievement, proud of that as well, and a nice moment. But I'm sure Andreas would also be the first to say, you don't do research on your own, you do research as part of a team. And for the acute groin study, I already mentioned the NSMP. Thanks a lot for bringing the players to the clinic. And then the sports medicine team in the walk-in for calling Andreas and getting the players to come to him and be interested in being included in the study. And not forgetting the OPD nurses who assist with the inclusions as well. And if the players decide they want to be in the study, then we're also very dependent on having quick imaging. So here as well, a little big up to the three musketeers of radiology. Thanks a lot. And also to your team of radiographers who assist us by slotting them into MRI slots at all hours of the day to make these kind of studies possible. The acute groin injury study, when Andreas started his study, when you typed in acute groin injuries on PubMed, you found 2 papers. So there really wasn't much out there. And the project was set up to try and generate some fantastic data, give us more knowledge in the field. So the study involves all male athletes who come to walk-in with acute groin pain of less than a week old. They undergo clinical examination, a structured history, and then undergo imaging. And if their injury was filmed, either during training or during a match, then Andreas tries to get hold of the video, and that's giving us fantastic data. So have a look at this movie. Let me just hit the start button. Watch the number 7. He is coming to the ball. Something's happened there. It's not very clear on this one. Let's have a closer look. Holding on to his right thigh once again. So he's stepping out a little bit with the left foot to get the ball, and then sudden pain in his right adductor region. Once more. And from a different angle. Once more. Ooh, where's the mouse? And again. And the last time. Stepping out with the left. And this was in fact a total rupture of the right adductor longus. So these, I was quite surprised when we looked at some of the videos as part of one of Andreas's studies, that a lot of the movements where these big injuries are occurring, they don't actually look that violent. When you see it, you wouldn't immediately think like, oh, that's a terrible injury, I don't think. But here we see that this is a good example of a complete rupture of the adductor longus. So, and that's a study that's ongoing at the moment, analyzing more than 20 videos of these injuries occurring. So Andreas has been very productive to get his PhD done, and I just want to present some of the recent publications. The first one is on whether or not we can look at these kind of MRIs in a reliable fashion. So 75 athletes are doing inter and intra-tester reliability, and we see that the scoring, the measurements, the grading of these injuries can be done very reproducibly by experienced musculoskeletal radiologists. So that's an important kind of foundation stone to go on and do future studies. So we can reliably assess the imaging. And then a fantastic study of 110 acute groin injuries that came through walking at Aspetar. And what we see is that the vast majority of acute groin injuries occur here through football, and that 40% of football injuries occur by kicking. So that was one of the quiz questions as well. Kicking is the most common mechanism to sustain an acute groin injury while playing football. Again, 2/3 occurring in the adductor, and the majority, 9 out of 10 acute groin injuries, being located in the adductor longus. And of the acute groin injuries that come into Aspetar, 1/4 are imaging negative, so no abnormalities on the MRI or grade 0. And that left us with the question, would it be possible to try and predict when you'd have a grade 0, and can we locate where the injuries are based on clinical examination? So that led to the next study, which was, could clinical examination predict the presence or location of MRI findings? And 81 athletes in this study with the standard history, clinical examination and MRI within the first week. And the first question was, could clinical examination predict a grade 0 injury? And the answer is yes. If all your clinical examination tests are negative, so you do resistance, stretch and palpation testing after an injury, and you can't reproduce injury pain, then the MRI will be negative. Quite often in clinical practice, you might have a strength test where there is some injury pain, but on palpation there's no pain to be found. And in these cases where some tests are positive, some tests are negative, then palpation has the best negative predictive value. And we see scores above 90% for being able to predict a grade 0 MRI in the adductors and in the hip flexors. So clinically useful information there in terms of us as clinicians thinking whether or not we want to request imaging. How about the other way around? Could you predict a positive MRI? And the answer is yes in the adductors. So clinical tests are good at predicting MRI injuries and locating them in the adductors. So if you do clinical examination and you find pain in the adductors, the chances are very high that that's where the injury will be. The hip flexors is much less accurate. So if you think about distinguishing, is this an iliopsoas injury, is this a rectus femoris injury, then the positive predictive values are much worse. We can't be so confident based on clinical examination to locate the injury and say, distinguish, is it in the iliopsoas or the rectus femoris. Looking forward with this fantastic data that Andreas has collected, he's working at the minute on 2 really nice papers looking at specific location of injuries. There are specific recognizable patterns to these injuries. And then using that, we'll be able to go forward and look whether or not clinical examination or imaging can predict the prognosis. That will help us better determine the role of imaging. And the treatment study continues to grow and grow, that we'll better be able to decide what's the best treatment in these things. And I think this field is again a real opportunity for Aspetar to keep its position as a leader in the field of groin pain. The next ex-woman is Mystique, who's Rachel Taylor, UK trained sports physician who's now in Australia, who came here as a sports medicine fellow. And she worked together with the team in groin pain clinic, looking at patients that Zarko, I, Roald and Philip had seen coming through the groin pain center here. So as the patients came through, Zarko or I examined them, and then it was recorded what kind of problem that they had. And Rachel went through 100 consecutive athletes and looked at what they'd had. What we see is the vast majority of groin injuries coming to groin clinic are males. About 2/3 of them are professional athletes, and they came from 31 different countries, and the majority are football players. When we look at the problems that they had, and this was a quiz question again, we divided them up into the entities, and we saw that 44 of the 100 had multiple clinical entities. And why is this important? It means that if you're examining an athlete with groin pain and you find one thing to be painful and positive, don't stop. You've got to continue and examine the entire region thoroughly, because about half the time you'll find other problems as well, and this is clinically relevant. Again, adductor-related groin pain, very common, but inguinal and iliopsoas also occurring quite a lot. And interestingly here, we don't see that much hip pathology. Only 10 cases of hip-related groin pain, and some of them, the majority of them were combined with other things as well. So the hip as an isolated injury is very unusual here in Qatar. The next study is one on return to play. At the IOC conference in 2014, I met Ian Schreier, who's a Canadian epidemiologist. And he's big involved in thinking about return to play. And he did a workshop that got me thinking about the way we think about return to play decisions. So when we came back with the help of Andreas, together with Arne Lauk, who I think you'll all know from the hamstrings and rehab, then we set up a study thinking about return to sport. And return to sport's really hot. A lot of people who have worked at Aspetar were involved in a consensus statement on return to sport that was held in Switzerland last year. And at this consensus meeting, they proposed a model for how we think about and how we can approach return to sport decision making. And part of this model involves a process of risk assessment and then deciding how we accept or tolerate that risk. So a biopsychosocial rehabilitation model that has on the one hand tissue healing and on the other hand tissue damage, and we try and guide the athletes back to a successful return to sport. And when they're close to the end, then we reach the point where we're going to decide if we think they're ready to go back to sport. And this was originally the Creighton model of return to sport, and Ian Schreier republished this, being called the START framework. And it involves two main steps. The first step, if you think about step one, here you've got tissue health, and here you've got tissue stresses. So that's just saying, step one is thinking how recovered is an athlete, how fit, how ready are they? And step two, what are the demands they're going to face? What position do they play? What kind of matches are coming up? How much have they got to train? So based on that, you're thinking about the recovery versus demand. You're going to make some kind of estimation of what's their risk of re-injury. So you use your clinical knowledge and you decide they're about this likely to get re-injured if they go back to play. And risk is never zero, so there's always some risk. And then the third step, down at the bottom, is that you decide, is that risk acceptable? So that's a team decision where you have to then decide, okay, well this percentage sounds okay to us. Let's do it. Or no, we don't accept this percentage. Let's keep going for a bit longer and try and get that percentage down. So we did a study that's published in the JSAMS, and it was a pilot study. So in this study we had 10 athletes coming through rehab for groin and hamstring injuries, together with their treating sport medicine physicians and their treating physiotherapists. And thanks to all of those who took the time to fill in these questionnaires and answer the questions on this. And they were given this interview at the time of return to play. And they were asked to estimate, what do you think is the risk of a subsequent injury? And are factors other than medical factors, timing of the season, big game coming up, pressure from the coach, pressure from an athlete, are these factors affecting your decision? And we got them to estimate the risk based like this. So on the bottom, you gave a risk estimation. In this case, the person had said it's between 21 and 38% chance of a risk. And then you have 20 coins to drop in these 10 columns, and you distribute those according to how you think the risk is distributed. So the athletes, the physios, and the docs all filled this in, and that gave us a risk estimation. And so if we look how that looks in practice, we'll see here an athlete who's about ready to go back to play. And here, top left, we've got the expected number of games that they are due to play in the next 2 months, and the expected number of practices. So they needed to train for about 12 hours a week and play 10 games in the next 2 months. And then we've got here the athlete saying, I estimate my risk to be around 10 to 15% of having a subsequent injury. Next to that, the physiotherapist saying, I think it's between 20 and 40%. And finally, the sport medicine physician saying, no, I think it's around 70%. And they're blinded to each other. So these are all people thinking about the same athlete, but coming up with completely different risk estimations of how likely a re-injury is. And interestingly, this athlete did go back to play. All people accepted the risk, but then did have a subsequent injury, but in a different location. And here another case where we see the athlete saying, I think I'm around 10% likely to get an injury in the next 2 months. The physician saying, I think it's about 30%, and the physiotherapist saying, I think it's about 40%. And this athlete didn't have a subsequent injury in the next 2 months. So it wasn't a study to see who's right or wrong, but it's just about giving us insight is how we as clinicians arrive at these kind of decisions, whether or not we think somebody's likely to go back to play. And a quiz question coming back again here. Factors that affected the decisions. Factors were named by athletes, physiotherapists, or doctors in about half of the cases as having influenced their decision. And the 3 most common ones were timing and season, pressure from an athlete on a clinical staff member, or external pressure on an athlete to come back to play. So this is a study that I really enjoyed a lot, and I think it's a great subject for further study. And obviously it's not groin specific. You can do this with any injury or any illness, and we've got the questionnaire sorted out now. So anyone interested on working on this further, then please get in touch with us. We're happy to share this. Next member of the team, Magneto, aka Paul Dijkstra, who Matt mentioned as well already, the Doha study, the development of hip abnormalities. Paul's been working really hard on this. The hypothesis that sports loading at an early age may affect the morphology of your hip joint, and the plan is to look at this in a cohort of young football players and young swimmers here in Qatar. And 7th of February, Paul will submit the QNRF grant application for some funding for this big study. So we're really looking forward to that. And together with Paul and Professor Holmick and Rincha Agricola, who was here, we participated last year in the Warwick Agreement meeting on femoroacetabular impingement syndrome. So we were invited to go to the meeting in the UK. And at the meeting, it was convened because there's a lot of confusion, I think like groin, about terminology around FAI. So it was an attempt to bring together people in the field to discuss the terminology and then discuss the treatment. Now, I don't want today to do the whole meeting because that's, I think, a talk on its own, but just to say that the main things that were decided on, that we should call it FAI syndrome. So that really emphasizes that somebody has to be symptomatic to have FAI. So you can't have asymptomatic FAI, that doesn't exist. You have FAI syndrome, and if you have a cam or a pincer, we should call that morphology, not an abnormality, not a deformity, as we're not yet fully sure about the long-term consequences. So they seem like a bit small semantic points, but I think it's important when working within a team to try and use the same terminology. And the article's been incredibly popular. It's already downloaded more than 20,000 times in full text on BJSM, so it's having a big impact. And this was again one of the questions of the quiz: how do we then diagnose FAI syndrome? And here we can see that to diagnose it, you need a triad of symptoms, signs, and radiological features. So to say that an athlete has FAI syndrome, they should have symptoms that fit with that, they should have clinical signs on examination that fit with that, and they should have radiological findings of a cam or pincer morphology on imaging. So that's the nutshell summary of the whole Warwick agreement meeting. But it was really nice to be part of that, and I'm sure at some stage this will be presented in more detail here. Next member of the team, the elastic man, Žarko Vukovic, with his interest in the inguinal region. And Žarko, you'll notice I put you on a little French beret here, because Žarko has started the Bordeaux study on the histology of inguinal-related groin pain. So that study he went to Bordeaux in December to kick that off. And that's together with Gilles Reboul, our visiting surgeon from Bordeaux in France, and Alex Scott, professor of histology from the University of Vancouver, British Columbia, where the samples will be sent. So that's a study that's going to look at whether or not inguinal-related groin pain is due to a tendinopathy or a collagen deficiency. So as a sport medicine physician, I was always thinking about tendinopathies, and then Žarko, as a general surgeon with an interest also in hernias, was saying that hernias are due to collagen deficiency. So this is a study to look at what athletes have. Do they have tendinopathy or do they have collagen deficiency? And I'm really excited about seeing the results of this one come in. So in summary, I hope to have given you a flavor of the high injury burden in the QSL that we have here. Think about the 85 lost days and 21% of players being injured. The acute groin injuries, we can do MRIs and score them reliably. We can predict grade zeros, negative MRIs, and physical examination is very good at predicting and localizing injuries to the adductors, but not to the hip flexors. In the groin clinic, we see a lot of male football players, where 44% have multiple entities. So when you're examining an athlete with groin pain, don't stop once you find one thing. For the return to sport, think about how you estimate risk yourself. And I found it really useful. Try and be explicit, especially with yourself, about what percentage you think the risk is and which factors might affect your decision, how this kind of structures your clinical decision making. And then looking forward, obviously the ongoing studies of the screening and the acute groin, along with the DOA studies and the histology, really excited for the next chapter. I think I've thanked just about everyone. Thanks a lot to the members of the XMen team. It's been a great 1.5 years working together with you. And then continued support of the senior management of Aspetar. I really appreciate the support I get and that you afford me the opportunity to keep on coming down here. So thanks a lot to the Fabulous Four for your continued support. Cheers.